Good morning, good afternoon, everyone. My name is Benedict Walter from the Network for Improving Quality of Care for Maternal, Newborn and Child Health Secretariat. This is the 6th webinar in our series on delivering quality essential maternal, newborn and child health services during COVID-19. And today's focus is on respectful care, maternal, newborn and young child care. We have 4 speakers for you today who are going to share a very short presentation, after which we have 25 minutes for question and answers. Please, although you mute, type your questions in the chat box during the presentation, and the speakers will have a chance to answer them in the second half of this webinar. We will record this session, which is also broadcasted live on YouTube, and then send you tomorrow a link to all this information, the recording and all the presentation. We also invite you to join our committee of practice. You can see the link on your screen at the moment, where you can ask further questions for the speakers and they will take some time to answer you. I am now going to give the floor to today's moderator, Blota Malici, Dr. Blota Malici from the WHO. Blota.
Thank you very much, Ben. Blota Malici from the WHO, the Department of Maternal, Newborn, Child and Adolescent Health. I have the privilege to introduce today's 6th webinar in the series of delivering quality of care in the context of COVID. The webinars are co-organized by the Network for Improving Quality of Care for Maternal, Newborn and Child Health and the Child Health Task Force with the under the auspice of WHO and UNICEF. The series of the webinar had 2 main objectives. The first is to highlight the needs and the opportunities to maintain and strengthen maternal, newborn, and pediatric quality of care in the context of a pandemic. And the second is to share global guidance and learn from countries on approaches to maintain quality essential MNCH services. For today, I have the privilege to introduce to you the key speakers, and I'll start with our focal main facilitator and moderator, Dr. Emma Sachs from UNICEF. She's working on pediatric quality of care with the New York team. Dr. Emma Sachs will facilitate the discussion. We have 3 distinguished participants. Miss Charity Ndwiga. Charity is a nurse midwife from Kenya. She's a public health specialist and program officer with Population Council. Miss Charity Ndwiga will be followed by Professor Arti Maria, who is the head of the Department of Neonatology, and she's at the RML Hospital in New Delhi, India. And finally, we'll have an intervention by Mr. Hester Nyazalu, who is a director at the White Ribbon Alliance of Malawi. With this, I would like to hand over to my colleague Emma to facilitate the discussion. Emma, over to you.
Hi, and thank you. Good morning, good afternoon, good evening. We're really thrilled that so many people were able to join today. I'm going to be brief because we have such a wonderful panel of speakers, and I'd like to leave as much time as possible for discussion, but I just wanted to give a quick overview in thinking about quality of care, and I'm sure many people are familiar with this framework, the quality of care vision from WHO, and sort of the great importance that's put on experience of care along with provision of quality care. And I think we're going to hear more about the impact and effect of providing respectful and high quality experiential care for patients around the world. Next slide, please. So obviously there's been just a massive amount of wonderful work in the respectful maternity care agenda and looking at how women are treated and how all stakeholders involved are treated kind of during the maternity period in health facilities. And a lot of this work has had to do with choice and informed consent and participation. It's been really great to see such a growth in this area. There's been kind of a range of different challenges presented from some individual provider issues to a lot of health system issues where we see deviations from standards and norms and even sort of certain policies. So we're talking today about pediatric quality of care. And so I just wanted to sort of start by recognizing upfront that newborns and children have some unique needs for quality and respectful care when we think about how they fit into this agenda, right? So newborns and young children may have limited or some nonverbal communication ability and really rely on others to speak for them and make decisions in their best interest. They have to have a parent or guardian consent for that care. That involves being with that parent generally and having the parent or guardian be given full information about what's happening. However, some urgent care or surgery situations may involve the child being separated for some amount of time. So we'll talk a little about the communication issues around that. We know there are many shared rights that a child has with the parent, the right to be treated well, the right for the child to be consented for care by the parent, the right for the parent to consent for care for the child, but the child also has independent rights that we have to think about as well. And I think when we think about kind of expanding the time frame beyond intrapartum care, we also may be talking about multiple facilities. So there may be a delivery facility as well as one or more facilities where postnatal care is sought. And finally, there may also be needs for bereavement care in cases of stillbirth and neonatal death. That's also really important for facilities to be prepared to provide, even if they're rare events, given how significant they are. Next slide, please. So just a couple sort of questions we wanted to think about for today, although of course it will be open for many of your questions at the end. But we're really glad to have two speakers give country experiences, as well as a comment from White Ribbon Alliance about some efforts that are ongoing to provide high quality and respectful care to newborns and children. We also want to sort of always keep in mind what the needs of the healthcare workers are. This is true especially in high risk or urgent situations. And in keeping with the theme of this, especially given this exacerbation in COVID-19. So how do we continue to push for respectful and quality care given the additional stresses, resource limitations, panic, additional burden, et cetera, of such a massive pandemic. And I think we'll hear about that from the speakers. So both kind of what has been the impact of the epidemic on these efforts, as well as some potential thinking about solutions and ways forward. So I will end there and I will turn it over to our speakers. Thank you.
Good morning, everyone. My presentation is focusing on a study that is looking at interventions to respective care for newborns, infants, and young children up to 2 years in 2 counties in Kenya. And this presentation is about how we sustain these interventions during the COVID-19 response. Background, quality of care remains central to newborn and child health outcomes. And this is well articulated in guidance from WHO on MNCH and child health, small and sick newborn quality of care frameworks, and recently COVID-19 MNCH guidance. We all know that increasing coverage for interventions alone do not deliver outcomes needed to reduce mortality rates. Care for the newborn and young children is well addressed in the standards for provision of care, but utilization is given to experience of care. Limited experience exists on how to include parents and families in care for their sick children and sick babies and children up to 2 years in low resource setting. COVID-19 may definitely affect experience of care for newborn and children in this resource setting. We conducted affirmative research for this study late last year, and we wanted to determine the manifestations and types of mistreatment of young children up to 2 years old in Kenya, in these 2 counties. We also wanted to identify and explore drivers of mistreatment, understand how family engagement influence experience of care, and with these findings, prioritize program activities that, to improve experience of care. On the mistreatment of care, we found, and we present here by age group, 0 to 28 days and an infant 29 to 2 years. We find that verbal abuse and concerted care and lack of communication occurred similarly to the 2 groups, but newborns tended to be to face delay of care and also tended to be neglected or abandoned, while infants repeated to face faced repeated tests without explanations more commonly. As you can see here, we see here 2 mothers, one complaining about how their babies were abandoned, while the other complained how the doctor was not taking into consideration the pain being felt by the child. We look at the drivers of mistreatment. We find these are overlapping. We find drivers at the health system level. We find socio-cultural drivers and individual drivers of care. For provider drivers, we see lack of communication experience, which leads to poor diagnosis, unnecessary tests, and incorrect dosing of drugs. We observed that. We also find insufficient emotional support and counseling skills by the providers, which leads to negative experience of care for the newborn and the young child. We also found that providers tended to get distractions and from phone and TV, and therefore neglecting their care. There was also heavy workload and inadequate supervision, poor communication between doctors and nurses, and here because of heavy workload, doctors used to see patients alone, and we observed that they would there was lapse in communication, leading to poor continuity of care and neglect. For the providers, there was also poor and inconsistent remuneration. And we also saw that providers believe that increased family engagement results in more infections. We now look at the communication from more aspects, that is from the provider and the parents. And you see that provider-caregiver dynamics seems to be in play. If parents seem to fear providers, there is also inadequate, they also they don't adequately respond to caregivers' needs, and the caregivers also felt powerless. And you can look at those quotes from focus group discussions and in-depth interviews from women and from parents. Looking at the role of men in caregiving, we find again there is limited access to newborn units and pediatric units, as reported by one healthcare provider for men, and therefore there is less communication. They tended to know little or to communicate to the providers very little because they have no access to the newborn or pediatric units. Our that objective was to look at the barriers to family engagement. And we found that there is lack of knowledge and ignorance by the caregivers. The parents also lack technical skills to do some of the activities in care for the newborns and their children. There are some caregivers that were not or uncooperative and not ready to run, who felt that being asked, for example, to feed their babies when they were sick in newborn units should be done by the providers, and therefore they tended to be uncooperative. There was also lack of mutual respect between providers and family members. Systems do not allow parents to do certain things. Providers fail to demonstrate some activities, the how to, for parents, especially those with no previous experience or of having a sick child or a baby admitted in a hospital. Providers were also are also too harsh and also have a negative attitude, so therefore they are unapproachable. Although we did this baseline formative study before COVID-19, and with it comes concerns and providers, concerns and fears, and we have provider concerns in the fear infection, there's inadequate PPE, psychological stress associated with long working hours. They are also separated from their family, and there is the stigma when they get infected, or just because they are caring for people that have been infected with COVID or exposed with COVID. For parents, there is the fear of infection, and this led to delay in seeking care, or they refused hospital admission. Some facilities were closed to make room for COVID-19 centers. And for those that are open, they remain to operate suboptimally. There is also reduced income because people are not working, and that has effect on health expenditure. And there's also the issue of stigma. At the health system, or the resources were shifted to COVID-19 response. The human resource was further constrained by now to man the COVID centers and also to do follow-up. And then there is the issue of mistreatment of healthcare facilities. Now, we did have come together with all the stakeholders, that is mothers, providers, and managers, to develop our intervention and a theory of change. And although our intervention has not started, we are planning how to conduct this intervention within the COVID-19 context, and we hope to start in the next 2 weeks. And the intervention that you're going to carry out, we are going to have nurturing care as our basis for care, and for the newborns and the infant and toddlers up to 2 years. And we want to make sure that the environment is responsive for nurturing care. And to do this, we will orient providers on nurturing care, and we'll also have emotional support. We'll also orient them on emotional support, and also have interventions that are geared towards supporting the providers emotionally. Our second intervention will be about coaching parents on how to do nurturing care, and also emotional support for providers, particularly when their children are very sick, or just because of their sickness, or in relation to the babies being admitted. To do this, we will need to also monitor for structure change through the existing mechanisms such as the health facility management teams, and also the quality improvement teams within the facility. We hope that we will, by doing this, we will have improved efficiency and feedback within the health facility. We have more motivated and supported providers, and we shall also improve provider and parent linkages. And in so doing, we will ultimately improve newborn and toddler health. And also we have more informed parents and empowered parents, and also we'll have reduced an environment that reduces parental stress. Now, in this slide, we present how we are going to implement our intervention to mitigate the COVID-19. For the orientation, provider orientation, we are going to do this through Zoom meetings, and we're also going to have WhatsApp group to facilitate peer interactions among the providers. For coaching and emotional support for parents, we are also going to use digital, where we are going to send information, an information brochure that we have developed through SMS and also through WhatsApp group. Through this parent WhatsApp group, providers and parents will be interacting, and they will be talking about how to perform certain tasks while they're within the facilities. For monitoring for structural change, we will have a feedback form that will be administered electronically, and we, from our end, we shall monitor the information coming in, and we shall give feedback to the providers and to the parents concurrently. By doing this, we hope that we will be able to have informed and motivated providers, more improved parents, provider communication, and engagement and partnerships, and shared decision making, and also have a conducive health system environment for nurturing care and for management of sick newborn and children 0 to 2 years of age. Thank you for your time. Thank you for listening to me.
Good morning, good afternoon, and good evening. I speak on delivering respectful maternal and newborn care in the COVID times. The pandemic has severely challenged the capacity and flexibility of existing health systems. We all know that health structures have been having deficit to cope the burden of disease. They have required major restructuring and expansion. There is a wide no-skill gap. The labile policies, rapidly changing guidelines, translating them into unstable practices with challenges in implementation, and ever issue of supplies, equipment, and logistics. And with HR, shortage because of deployment, mobility restrictions, lockdown, sickness, quarantine, absenteeism. The attitude of both receivers and providers of care, one being of fear, phobia, and stigma. The adverse social impact of lockdown with mass migrations and economic crisis. It's not surprising that the paralysis of even existing essential health services has happened. And amidst this, we want to talk of quality of care, the maternal and newborn health, the respectful maternal newborn care, which is about care during and after childbirth, and all women have the right to attain high quality of care. So quality is not respectful care, and quality is not simply about treating a disease. It's about physical, mental, social well-being. It's providing the highest level of evidence-based quality of care, considering mother and newborn as a diet, creating a right to respect and dignity. So overall, it has to be an experience of warmth and caring during childbirth. Let me demystify a couple of facts before regarding COVID in newborn. The virus has rarely been found in breast milk, with rare possibility of replication and transmission in breast milk. There are potential protective factors in breast milk, the risk of vertical transmission almost nil, and at worst, the disease is only mild, occasionally moderate. And regarding breastfeeding, we know that among its benefits, the skin-to-skin care, KMC, the benefits far, far outweigh the risk of transmission of virus, and the benefits of rooming in are more than the risk of transmission. So the risk analysis actually clearly says the benefits of breastfeeding outweigh the potential risks of COVID to the newborn, and knowing the impressive cost of not breastfeeding forms the rationale of the recommendations, which all of them unanimously have advocated skin-to-skin care, rooming in, and breastfeeding. But keep in mind maternal autonomy and right to choose on a case-based decision. But let me put a question. For COVID-positive moms, are these guidelines implementable or are they illusionary? For instance, early and uninterrupted skin-to-skin contact at birth, in COVID times, in vaginal and cesarean, and continuing KMC as soon as possible. Direct breastfeeding, mothers rooming in the babies day in, day out, but keep a 2-meter distance. Is it possible? So is it bedding in or rooming in? Continuous supply of express breast milk must be given to babies who are kept in nursery, and formula should be avoided. Is it possible? So with all these enigmas in mind, we thought of taking up a formative research in our Department of Neonatology. The project is WHO funded, starting in July 2020 and still ongoing. We hypothesized there exists significant knowledge gap with respect to establishing successful breastfeeding among recently delivered mothers with suspected or proven COVID. And this was in a facility-based setting in our hospital in North India. The objective was to identify the enablers and barriers to breastfeeding in a facility setting in COVID situation, a mixed method study. We did in-depth interviews and non-formal interactions for all stakeholders involved, involving the mothers, their families, the residents, the faculty, the lactation support staff, and head of gynae department, OBG department. Thematic content analysis has been done, and we are ongoing, and to determine the determinants or the barriers and enablers for breastfeeding. As they emerge, I'll share with you some of the barriers. We found challenges with the guidelines. People thought they were labile, not implementable. They were more utopian. Classification of abortion as a non-essential service early on was not approved by people. Doctor and patient interactions have virtually reduced because of duration and frequency of exposure that the doctors want to have with the patient, thus providing lack of opportunity for counseling, especially in face of shortage of staff and skill. Anxiety, fear, and stigma with lack of support to the mothers. Moreover, the families disowning the mothers in isolation ward, leaving them depressed and desolated amidst the financial crisis and the mounting stress within families. Regarding the compromised maternal and newborn practices, it is understandable people started preferring to deliver at home with the associated risk of asphyxia and other adverse outcomes related to perinatal period. There were fears of institutional delivery. Coming to the hospital itself was a risk factor. Increased cesarean rates, care at birth severely affected skin-to-skin, separation of mom and baby became routines. Breastfeeding was delayed, not only initiation because of lack of support, establishment also, and possibly continuing. And this was exploited by none other than the infant food industry. They made their way into increased formula use and advocacy. The newborn care has not been prioritized at a lower level or the administrative level of the hospitals. However, nationwide, of course, it is the biggest priority. Inadequate follow-up because of fear, mobility restrictions, unavailability of contraceptive services, commodities, and shortage of emergency transport, access to care, limited COVID testing, disruptions of routine maternal neonatal services, they all form the barriers to exclusive breastfeeding. Let's come to the positive side, the half glass full, the enablers. So zoning was done in our hospital. Strategically, areas were identified and zoned into red, green, and orange areas. For instance, I will just give you spatial orientation in our neonatal maternal services. Although they appear adjacent, these areas are widely apart, zoned into green, nursery, the red, the labor room, and the COVID positive and the suspect others. We undertook, the hospital has taken big initiative for capacity building, IPC trainings of all stakeholders, all levels of staff, IEC material displayed widely, and there was psychological support really required for just mothers as well as for the healthcare providers, and our hospital has taken good lead in doing this. OPDs have evolved measures to allow safe visitations, social distancing, floor markings to allow that antenatal OPDs are attended but less crowded, thermal screens are done. So what specially about the respectful maternity and newborn care in our hospital that we have been able to do? So skin-to-skin care in COVID-positive mothers, as you can see, is being practiced. It has been challenging, but we're doing it. Then rooming in and lactation support, we are trying to do as far as possible for babies who are well and mothers who are well. Practicing the WHO recommendations of respiratory hygiene, a mask, washing hands, and routine disinfection of surfaces. As you can see, the mothers have bedside sanitizers, and there is sufficient spacing. We have a nice maternity COVID isolation ward where we are practicing rooming in. Issues that remain unsolved still, that for maintenance of supply of milk to the baby who's in nursery separated from mother because of sickness, how do we manage this supply of milk? Because we need to have somebody taking the milk every 2 to 3 hours from a COVID positive area to a non-COVID area in zipper bags, maybe. And then somebody has to take it, and from COVID into non-COVID, all those issues are there. Availability of breast pumps, wash areas, disinfection, utensils, disinfection of breast pumps. How do you do it? Who does it? Lots of things. We are still evolving. Maybe it's work in progress. Lactation support in postnatal wards is being provided. The innovative use of telemedicine has helped us to think. We are doing telephonic follow-ups for continuation of breastfeeding. Tablets have been found very useful. One hospital, GTB hospital in Delhi, has innovated this practice to use tablets. The mother can see, the nurse here can see, and the babies can be shown to moms. Otherwise, it was days together when the mother had not seen the baby. And a topic close to my heart, family-centered care. Yes, we were the nodal and the pioneering center, and we have continued to do it in a modest way. You can see mothers being trained in a group, the mothers being taught to hand wash, and this is family-centered care at its best. This case study, I would like to share. Salma, a chronic renal failure patient with chronic dialysis for the last 3 months, admitted with us. Baby was about 700 or 800 grams, 600 grams or so. She maintained her continuous supply of express breast milk, thanks to her mom-in-law and her husband. What a fantastic support they provided. Father provided KMC in the nursery. The baby was discharged thanks to this great concept of family-centered care that they actually exhibited. The developmentally supportive care, KMC, participatory care, all that. I've already mentioned the challenge of access to these babies in the nursery for providing maintenance of supply of breast milk. We have adequate resources. We are managing, making sure every healthcare worker is safe. Babies are transported safely as far as possible. There is counseling facility for mothers and healthcare workers, and an opportunity our psychiatric department came forth with telephonic counseling for our healthcare workers, which was commendable. Routine newborn care and follow-up did not suffer that much. Actually, these things we have been able to evolve with time. They were not initially, we have had to challenge and struggle to reach here. The newborn hearing screen, the new follow-up in the neonatal OPD, ROP screens in the nurseries, vaccinations, and high-risk follow-up clinic. We have resumed these activities more or less. We celebrated recently the Breastfeeding Week on 4th of August, and you can see the enthusiasm and the whole depiction of breastfeeding safety in the COVID times. It was wonderfully attended, and I think a great effort with participative involvement of all nurses, doctors, and all healthcare workers. This is where we want to be, a respectful maternal care. And you can see outreach and community programs have been labeled by our country as essential. I just want to conclude. We perhaps now know what to do, but not yet quite how to do. However, so far, to provide a respectful maternal newborn care. A, safety first. B, communication, education, psychological support to both receivers and providers of care is of paramount importance. C, a strong leadership on the top, interdepartmental coordination is extremely important. Innovate the indigenous ways and there is a need to contextualize and adapt the guidelines to be feasible, effective, and sustainable in our own setups. Mother and newborn must be considered as inseparable diet. Strong maternal newborn diet support through peripartal, birth, and neonatal period is required to make RMNBC a reality. For example, birth companions, lactation counselors, they can be harnessed. Leveraging upon family-centered care still seems promising. It has stood the test of time. Community empowerment will ensure continuity of care, cross-learnings with opportunities as this webinar are great opportunities. So I would conclude by saying, give the care that you wish to receive. Together we can. Thank you very much.
Thank you.
Thank you so much. I want to turn this over for just some very brief comments from Hester Nyasulu from the White Ribbon Alliance. As people know, the White Ribbon Alliance has hosted the Global Respectful Maternity Care Council and has done a lot of work on advocacy and policy. And I encourage people to put questions in the chat. I'm compiling them and we'll have all of the speakers live to answer them shortly. So over to you. Thank you.
Thank you so much, Emma, and greetings from White Ribbon Alliance, Malawi. Just to give a comment to the two great presentations that we've had here. White Ribbon Alliance did a global campaign on what women want. And in this campaign, we did it in 2018, 2019, covering 414 countries, asking women their top demands. And the issue of respectful care came out as the top. So today it means that we are discussing an issue which is very critical and also which is universal and much needed from the women and girls out there, and especially also the newborns. And yes, in this era of COVID-19, the need for respect is even more pronounced. We did some phone interviews and radio interviews with women and girls here in Malawi. And clearly the complaints about lack of respect came in, and they were talking about no attention, neglect, being sent back, not being examined properly. So all these were coming because at some point we also discovered that our nurses and midwives had no PPEs, and it had to take a lot of advocacy. And even it went up to the sit-ins from the nurses and midwives themselves for the government to act. Now things are slightly better. But in terms of the policy now on the part of White Ribbon Alliance, we have made sure that when the government was reviewing the quality of care assessment toolkit, that the issue of respectful care needs to come out, and that the exit interviews should include the issues of respectful care, asking the clients, the mothers themselves. And also recently, the Ministry of Health has developed the guidelines, MNCH FP guidelines, guiding during the COVID-19. And in these guidelines, we also advocated that we should be clear and bring to print the issue of respectful care. And moving forward, the other area that we are seeing an opportunity for policy adoption or change is where we are looking at the revised respectful maternity care charter, that we should adopt that one in Malawi, where it has components for children's rights and newborns' rights. And also very critical is that the government should employ more midwives so that at least it eases the pressure and that mothers are able to be supported more with more quality and more care. So those are the policy areas that we're looking at, and we thought that this could add to the great presentations that we've had today. I hand over to you, Emma, to proceed with this.
Thank you so much. And thanks for kind of putting this in the context of the supportive policies that are needed in order for these facilities to be able to provide this care. Please continue to put questions in the chat. I'll start with two that I think are COVID related. But first, can I just check? We should. I'm thrilled that we have all the speakers live to answer these questions. I don't know if the video will work, but can we just check that they can both speak? Charity, are you able to speak?
Yes, Emma, I can speak. Thank you.
And Artie as well. Okay, well, I'll pose this to Charity first. Artie, hopefully, if you're on mute, you can answer after. But I think two questions that are really directly related to COVID. So one was a question about, the difficulty of balancing carrying out a study versus providing care during COVID, when especially the resources are very stretched already. And so maybe just a couple words about how we can balance those, as well as a question about physical infrastructure. And we know that that's so important in order to allow the sort of most participation of families and sort of a larger care team, if you will. But of course, that's been a challenge in COVID. So maybe that's another kind of area of balance that you can speak to. So Charity, I'll ask you to speak first, and hopefully we can get RT live after.
Thank you, Emma. On the issue of continuing research in the COVID-19 pandemic, I think it's an important one to think, but we also need to answer questions about the care that you're providing and how experience of care or respective care is presenting itself, is manifesting itself in these difficult times. And for us, we are doing an implementation study so that we are running as we do the study. We are going to work together with the health facilities. We identify what, once we have the orientation of the providers and the coaching of the mothers, we identify what the facilitators are, what barriers are there, and then we also identify the opportunities for, improving. And in so doing, we are not only supporting the Minister of Health policy of encouraging women to seek care, and also ensuring that there is high quality standards of care for newborns and young children 0 to 2 years that are admitted in health facilities, in the study facilities that you're working. So we are not only going to answer the question, but also going to ensure that the facilities they are providing care and services that they are supposed to get. Thank you.
Thanks so much. Artie, are you able to join us live?
Yes, I am. Okay.
Wonderful. Thank you. Go ahead.
You cannot join. I think the host has stopped my video, so you need to put it on. My video is not getting on. Hello?
Yeah, I don't know. And if we can turn the videos on.
That's okay. That's okay. Well,
Archie, we can hear you.
Sure, sure.
So yeah, please, if you could just talk about the balance between, you know, doing a study and providing care, as well as some of the issues around maybe the physical infrastructure changes that had to happen for COVID and how that has had an impact on participatory care.
Yeah, so it has been an iterative learning. It's not been like whatever I have shared with you today. It's not what happened right at the outset. So it has been very challenging. We didn't even know, because this is a first time ever for anybody. So nobody has had the experience. In fact, we learned by doing the wrong and then learning and doing the correct. And then still we knew this was evolving. It was not the final thing. So there was nothing like a final thing. And still, I think it's work in progress. So to say, for instance, zoning and, you know, creating structures out of the same structures, we had to segregate. We had to suspend many of the non-emergent activities. OPDs were suspended. There suddenly our own ward, you know, like your own places, everybody had to get together and nobody could say, this is my department, my beds, my ward. And everybody had to let go. We had to work at a unison at the level of a hospital, look at it from what are the bigger needs. So the vision had to be there. And we had to see that, you know, this entire area will be the green area, this will be the red area, etc. This had to be there. And then we had to just see that what fits in best where. So but there were certain things which were fixed. For instance, the labor room maternity is fixed. So we had to juggle around that. So certain things were fixed and we had to move things, we had to manage and create structures around it. But then there were things which could be moved and could be recreated. So they were managed there. This is about infrastructure. But definitely, even like my own department, new building was coming up. It was almost ready to move in. We have been really like taking it hard for many, many years to make it happen. And just as it was ready, it is now converted to Corona Screening Center. So I was very, very like saddened. But in the bigger picture, I really feel this has been a little contribution because it is serving a good job. I mean, good service for people. So similarly, we've had lots of challenges, and then challenges of the sort that, you know, you did create an infrastructure. We did create a COVID isolation ward, but then the nurses, the HR forces, they are deployed. They are like common because you can virtually imagine only half the people are working because the rest half are on the quarantine for the places like the COVID wards. So if half people are only available, we had to pull in from all the departments. It was not like the OBG department and maternity department alone is providing nurses for the maternity ward. Now the ENT, plastic surgery, and all these emergency nurses are also part of that. So they have no training, they have no exposure. So there is a lot amount of sensitization and actual trainings and skill building required. Otherwise, mothers will not get, there is a disruption of the care. And let me also share that the maternal services like the normal one, the normal breastfeeding, I could boast that we were doing 100% breastfeeding before discharge for the normal babies. But I actually cannot say that today because what happened, the fear factor. And the mothers wanted to remain in the hospital for the shortest time. They just delivered and they are asking for discharge because they think being in the hospital means they will acquire COVID. So when they want early discharge, baby is not even sure to be discharged or not. There are problems. Mother's breastfeeding is not established. It's not even initiated very well. And they are just, because the family insists they have to go home. And once they go home, they have taken one formula feed and that goes on. Then it's more of a story that the relactation and this. So we are grappling with lots and lots of challenges, but I think we are doing better than yesterday, and I'm sure we'll do better tomorrow than today.
Thank you very much. I know it's very much an iterative process, and everyone is really learning and trying their best as we grapple with this difficult situation. We got another question sort of noting that, especially with some evidence that there may be increasing stillbirth with the COVID pandemic, have there been sort of any efforts to address this, potentially sort of strengthening the efforts around bereavement care as this sort of becomes more and more important? And so I'll pose that perhaps to the two speakers, but also Hester, if this is something that is on the advocacy agenda as well. Charity, I don't know if you want to start.
Yes, thank you, Emma. Yes, this is true for the counties that you're working in. One, because we know mothers have not been attending to antenatal care as they should be. And therefore, maybe if they had problems like malaria, they tend to get babies earlier. And yes, there have been efforts by the Ministry of Health, and I just want to say from the onset, we have not started our intervention, so I cannot give what we are doing in relation to that with the intervention that we are planning to do. We are starting the intervention in about 2 weeks' time to come. So yes, mothers have been, advised to come to the hospital for deliveries, for antenatal care. And one of the things that we know we will do when we start our intervention is really to support mothers that have lost babies. Like I did report earlier, maybe not very exhaustively, because at the time I had, we have a very, in our training and in our intervention, we have an elaborate sessions where we shall counsel mothers that have lost their babies or whose babies are very sick and critically ill to the point of dying, and they need care. And this is a major gap that we found during our formative study. And this has continued to be seen. We are just analyzing the baseline data now. So this is something that is true, and mothers need support through bereavement. We are going to deploy counselors within the health facilities where we are going to be working, and this will be counseling mothers that are, experiencing stillbirths and deaths of infants, of newborns. So this is what we are going to do. But really, we haven't started our intervention, but I think this is already giving us an impetus to really plan well because we have been interacting with these health facilities. Over to you, Emma.
Yeah, thank you. Arti, did you also want to speak about any efforts related to stillbirth and bereavement care?
Honestly, I would not like to, because A, I don't have the data. B, I'm not the expert for this, so I don't think I should say anything on that.
Okay, that's fine. Thanks. I know this is something that a lot of people are interested in, and hopefully there'll be more work on this. Hester, I don't know if did you want to say anything about the advocacy and policy side around this?
Yeah, I think also from our side, this is one of the areas that we have been thinking to put on the ladder and clearly come up with an advocacy strategy and agenda on how the government can address this. So it's something in the pipeline, but very, very critical. Before, our focus was to encourage mothers to go to the health facility. And we are winning on that because from our figures, 91% of pregnant women are going to the health facilities. But I think that part on now what happens afterwards is something that we need to look at and put systems on how the health facilities can handle such situations. So it's work in progress, and we should be able to report in the next meetings.
Great, thank you. And I know I see there's a comment too about our measurement issues around this. So absolutely, I think something that we have to continue improving the care, as well as our measurement systems and data systems in order to capture this better. So I think we only have time maybe for one more question, and I'm going to use the chair's prerogative to ask. But I will just say, please continue to put questions in the chat. Make sure it says all panelists and attendees. We'll actually share these with the panelists, as well as any that are posted on the community of practice. So please do continue to do that. And you can post in other languages, and we'll help get them translated to get answers from the panelists as well. I just wanted to sort of take the last question to say, we've obviously talked a lot about challenges, but is there any silver lining potentially of having more attention, maybe more resources, more concern about quality, et cetera, because of the pandemic and some of the kind of attention that we've had? And is there sort of an opportunity to use this crisis as a place to jump off of and build off of, having illuminated some of these challenges? So I'll give everyone just a final brief thought before we close. Charity, please.
Thank you. I think COVID-19 brought in an opportunity to really expose the weaknesses within the health system. And now more so that quality of care is something that is very central, is something that is now being driven globally and at the local level within countries. I think we do have an opportunity, even when the resources are constrained, first for increased advocacy, to point out now the need for governments to in future, allocate additional fundings for newborn and child health services, and also the need also to look at the provider's perspective. We know that there is shortage of protective equipment, but other than that, there are also other needs that are very relevant to health providers, that, like the issues of training, support, and support supervision, and ensuring that there is a dialogue between mothers and parents that really needs to be addressed. And then it is becoming very obvious that there is an obvious gap for interventions that are out there, and therefore we hope that, for example, the research that we are doing will be very important to inform the facilities, the government, and the world at large in this type of settings during the COVID, how to better, improve resources to care to improve the quality of care from both the parents and the provider's perspective. Over to you, Emma.
Great, thank you. Arti, do you have a very brief comment on that as well?
Yeah, I think so. This has been like everything has every cloud has a silver lining. So as you said, we can look at it as an opportunity wherein this is brought attention to the issue of quality of care and respectful care, something which is not there. Then we realize that it is so important and vital. Then, innovations like use of telemedicine or using distant ways to, communication. We can reach out to people even virtually. So there's a lot of things. Potential is there for things to be explored, new ways to be explored, how we can improve the existing systems. Then the issue of, the family-centered care again. Because I think leveraging family support is ultimately what is going to give social accountability of health. And health belongs to people, so that's where we need to build it and build it and capacitate the family and the mother to look after the baby. And I think birth companion concept is very good. And the other issue is the lactation counselors. I think they need, and midwifery, they need to be pushed, because as you said, the stillbirths and the quality of the childbirth experience in the mother, I think we need to expand on those realms of midwifery and even the lactation support and lactation counselors. And I think psychological support and counseling and communication, they remain the mainstay for getting this pandemic out, the people, getting them out of desolation and isolation and desperation and despair and depression. I think that's it.
Yeah, super important. Thank you. Hester, any final lessons for us about policy and advocacy that we can take forward?
Sure. I think one of the things that we have seen with the COVID-19 is the strength that has brought in both from the health worker side to stand for their rights and the need for PPEs, like for the case of Malawi, where even the government had to respond at all costs. And also government responding in employing 2,000 more health workers during the COVID-19. So I think that's the part that has brought in that opportunity for health workers to come together and voice out their needs, which we need to build up. But also from the community side, I'm seeing where the communication has gone about COVID-19 and what people need to do and what to expect at the health facility. We can use the same, build on that, and ensure that people know about their rights and that they're able to demand them. So I think those are the areas that we can also be looking at and see building on the opportunities that COVID-19 has brought in terms of policy advocacy.
Wonderful, thank you. And I want to thank everyone again. I know we're struggling with time zones, with being on Zoom all day. We're running a few minutes over, but I did want to thank both the all the panelists as well as the participants. This is a hugely important topic. I hope everyone will continue to stay engaged through the webinars and the community of practice. And I will turn it over now to Blerta to give our final closing. Thank you.
Thank you very much, Emma. I would like to thank the panelists. I would like to thank Emma, the moderator, and all the participants for the excellent discussion that was happening in the chat. For more information, we invite you to check the 2 links and documents that are shown in the screen, the guide for maintaining essential services at the facility as well as community level. Next, please. As we go forward, we would like first of all to inform that all the materials in this webinar and other webinars, you can find it in the link that is in the screen. You will receive the registered recording of this webinar by email tomorrow. And at the same time, we'd like to invite you to join the community of practice, where we can continue the dialogue around other questions that may not have been answered during this session. The next session would be run, the next and the last session for this webinar series will run on 5th of November, and it will be on maternal, on newborn child integrated care at the community level. So for colleagues in Côte d'Ivoire, I will speak in French. Pour les collègues francophones, j'aimerais vous informer que les communautés de practice qui sont indiquées dans l'écran vont être, nous allons répondre aux questions en français aussi, et nous allons trouver une manière pour partager les présentations en français. Pour le prochain webinaire, on va faire on va donner de tout pour essayer et faire 7 webinaires en français, comme ça vous pourriez participer comme tous les autres anglophones. Thank you very much, and I'll see you in 3 weeks' time.